should probably start off by clarifying our stance. So what do we mean by brain scans should be mandated for teenage girls with behavioral disorders? Well, in the article we're given, it mentions that there has been an increase in behavioral disorders among teenage girls, whereas for males it's been about the same. And I'm hoping by the end of this argument I can sell you on why you should have them mandated. So essentially what we're trying to get is that it should be mandated to this high-risk, high-probability group because it will help us identify anatomical differences that we can use. And I'll get into the reasons and the methods by which we can use this information. So the very first point is that we're aiming to minimize misclassification. So behavioral disorders obviously is a very diverse set of conditions, and typically this is all bundled into a term known as conduct disorder, which is defined as a prolonged pattern of antisocial behavior such as serious violation of laws and social norms and rules. But this doesn't really say anything about the etiology of the disorder, which is highly heterogeneous, and includes components such as biological, psychosocial, and familial factors. So if we don't know what causes this condition, and this really diverse condition, how can we expect to treat it well? And you know, it's noted in the current diagnosis and treatment psychiatry textbook. It's difficult to disentangle this condition from several other disorders that also seem to get tracked into this one disorder, such as oppositional defiant disorder, ADHD, and substance abuse disorder. So currently, we're lumping all these teenage girls into this conduct disorder category, really without teasing apart what is the root of their problem. And if we do the brain scans, then we're able to see, okay, well, at least there's this subgroup that has this anatomical difference, and based on that, we can go ahead and separate them out as a different category. So eventually, we can do two things. We can give them the right treatment, and we can avoid giving them the wrong treatment. The other thing I want to point out is that we propose that this form of screening is similar to other forms of screening done within the school system currently. So I have two examples. The first of which is the hearing and eye exam. Now, I know this sounds like two different things, like the hearing and eye exam and brain scans. But I mean, when we really get to the root of what we're doing, we're looking at anatomical differences and other possible brain dysfunctions, because as you know, the ear and the eye also, the sensory information has to go through the brain. Granted, we're not doing it using a scan per se, but we are testing these things. We also do behavioral assessments because teachers are trained to spot certain behaviors in their school children, and they report these. And then those school children are then tracked to this counselor or psychologist and then get treated. But then again, we still don't get at the possible root of what their problem is. So we can't really effectively deal with them. And my last point, and probably most important, is as it stands, the prognosis for children with conduct disorders is poor. As they age, they tend to be unable to adapt to demands of adulthood and have major problems with relationships and holding jobs. They often break laws, placing a burden on society. And this is as stated by the American Academy for Child and Adolescent Psychiatry. So if we are able to know, if we do the brain scans and we know what's wrong with these children, we're able to essentially deal with them properly, and if we are able to deal with them properly, able to alleviate downstream effects that will happen as they age. And we can effectively turn them from, or reduce instances of breaking laws and stuff, and turn them into more productive members of society. And just a statistic I want to throw out there. Obviously, if they break more laws, they're at a higher chance to be incarcerated. So the cost of incarceration per inmate, at least in the state of California, is $47,000 a year per inmate. If you think about it, you can go from having society pay $47,000 a year to having this member society produce. So you're actually gaining a lot out of this, and this would also be an argument for the cost that you would initially impose by doing these brain scans.
All right, well, first I just want to thank everyone for coming. Thanks to Emory Neuroscience Blog for hosting this debate today. Just wanted to point out a couple of statements from our opponents here. I know one of the things that you mentioned is cost, and that's always a concern when it comes to medical treatments these days. You cited that it takes about $47,000 a year in order to house an incarcerated inmate. But if you take a look at the average MRI cost, the average MRI cost nationwide is about $2,500. And it can, in some areas, can run as high as $7,000 for an MRI. So if we're looking at that, best case scenario, maybe about 20 scans can be done a year for the same cost per inmate. And the estimated rate of teenage girls with, for example, oppositional defiance disorder is about 2 million. So we have quite a bit of scans to do and quite a bit of cost associated with that. So it's kind of a hard comparison to draw versus eye charts. And even if we have these scans, are we really, really sure that we can take that information and utilize it? It's kind of a bit of a far assumption to say, well, here's this brain scan, we can compare this to a control, we can compare this to other teenage girls, and have enough information to really then create this downstream treatment. So I think that we need to be careful when we kind of examine the future roles of that. Additionally, I think avoiding the wrong treatment is important, but do we actually have the right treatments available?
30 seconds.
So we can.
Okay. Do I get a chance to jump in here because it's a cross-examination, not a speech? So it's $47,000 a year, right? Mm-hmm. There's 2 million with that. What's the disorder again?
Oppositional defiance disorder.
So ODD. There are other criteria by which we diagnose these things. We're not saying to give it to every single one. We're saying to use it and correlate with these findings. So if what we're looking at really is not a
Okay, negative 6 minutes.
Okay. Our group opinion is that brain scans should not be mandated for teenage girls with behavioral disorders. First, brain scans are not sufficient to diagnose behavioral disorders. Behavioral disorders are a broad category used to group a range of more specific perceived difficulties in children and adolescents. These difficulties may consist of internalizing disorders like depression and externalizing disorders like ADHD and conduct disorder. We know there are no laboratory blood and genetics tests that can be used to diagnose most of the disorders, nor can brain scans. Instead, the diagnosis of behavioral disorders depends on many factors. Most of the behavioral disorders in children are inherited by their parents. These disorders are somewhat treatable, but a brain scan cannot provide information for treatment. In a recent study, Dr. Parkinson conducted brain scans for 22 teenage girls who had conduct disorder. Compare them with scan of 20 who did not, and they also checked the same scans against others previously taken of teenage boys with conduct disorders. The results show that both males and females with conduct disorders have smaller amygdala than their peers. And these girls also have less insula than their peers, but the boys with conduct disorder have larger insula than healthy peers. From this limited study, we suggest that it may be possible. They suggest that it may be possible to use these scans to spot problem earlier and then offer social or physiology help. However, the first problem of this study is that they only consist of 22 girls. I think the sample is too small. Can these 22 girls represent all girls with behavioral disorders? The second problem is that even though these girls with conduct disorders have smaller amygdala and insula, does this mean that all girls with smaller amygdala and insula have conduct disorders? Of course, the answer is no. The study is also questionable based on the fact that the boy has larger insula than the girls. It seems inconsistent. So the brain is complex, and we are far from knowing exactly how it works. So we can not say a girl has a potential of behavioral disorder only through the structure change of one region in the brain. In a small example, the onset of behavioral disorders depends on social, economic, and environmental factors. In further, we know that scanning these girls after diagnosis does not offer any effective treatment, so its mandate cannot be justified. In conclusion, brain scans should not be mandated for teenage girls with behavioral disorders. Thanks.
Cross-examination.
Okay, just to finish my point. Okay, so you said 2 million with ODD, right? So 2 million, and let's assume 0.01% of them break crimes and become incarcerated, right? 200 is the resulting amount that end up incarcerated times around 50,000. That's $10 million. Brain scans become pretty affordable at that rate.
Well, if you actually take a look at the cost of, if we were to brain scan every single one of those teenagers with oppositional defiance disorder, that's $5 billion.
Yeah, it seems like you're rather shortening the prompt to a very, very specific situation, whereas this is a rather broad question to answer about whether or not we should be using these technologies to look for these sorts of disorders.
Okay. In the interest of time, I'll concede that one. The other things that were mentioned were that there were a strong that there was questions about the study itself, but at least in terms of the whether the size of the amygdala correlated to behavioral disorders. But the way this would have been done is that behavioral disorders occur first, and then you do the brain scan. Not that you're doing it the other way around.
30 seconds.
Okay. So in the sense that you're looking, you qualify one thing first. You're not looking across an entire population and saying, okay, all girls with big amygdala, with all girls with this difference in amygdalas have behavioral problems. Rather, all girls that have behavioral problems that have this finding will have this finding.
Well, what's the point of doing the scans? What would that give you?
It gives you a target as opposed to saying a psychosocial reason or
Okay.
saying.
Dr. Carter?
Okay, so some of the points that were brought up, there was some doubt about the diagnostic validity of this as a test. Obviously, we're not trying to say that we should roll out the scanners and put one in the gym of every school in America. Further research obviously needs to be done before we can use it as a diagnostic test. But what this would allow us to do is to have an additional dimension in order to classify what is actually wrong with these teenagers with behavioral disorders. Again, as we stated before, these childhood behavioral disorders are often lumped in with things such as ADHD, ODD, and CD. This additional brain scan could help us disentangle those, which is very important because early treatment is critical for success in early treatment is critical for successful recovery. As we've stated, the prognosis for these children is pretty bleak without treatment. They often go on to break laws and behave in an antisocial manner. But with early treatment, when the brain is a bit more plastic in the teenage years, with therapy, you can actually reverse these deficits. Let's see. Again, we're only advocating the use of this device, or the use of this scanning on high-risk individuals, those that have been identified as having potential behavioral disorders. Therefore, that would reduce the cost because there's a lower population you actually do need to scan. Let's see. In addition, there are some doubts about the accuracy, but in this study, there's actually a very strong correlation between the amygdala size and the degree of behavior disorder. Another point that was brought up was that this is fundamentally different from a hearing test or a vision test, but I would argue that fundamentally it's not really that much different. Think about when you had a test for lice. when you had to get scanned for lice when you were in elementary school or middle school or wherever. They take you into the gym and they look at your head and they make sure you don't have lice. And the reason for this is because lice is not only harmful for you, but it's harmful for other children around you. Well, it's the same thing with behavioral disorders. The behavioral disorder harms yourself, it harms your future, and it can also harm those around you if you're acting out and affecting others in a negative manner. It's fundamentally the same. It's fundamentally not all that different. Obviously, it'd be a bit more expensive than looking at your scalp, but in essence, it's not all that different. How much longer do I have?
3 minutes.
Oh, well, that's pretty much what I got. So.
Okay, then cross-examination.
Okay, just as you mentioned, you said the cost is limited, it's not too much. But if it's mandatory for teenage girls, do you think who will pay this fee? And a lot of families cannot afford it, actually.
If it can be demonstrated to be beneficial, which I believe that it can, then the cost should be covered by insurance, which now is mandatory. You're shaking your head. Okay. Well.
And then you said if you just if you do this scan just for get some target of these girls, but do you think it's fair to these girls if they actually don't have this disorder? This was separated with the patient group. Do you think it's fair?
But then there are two hurdles they have to jump through. They have to exhibit antisocial behavior, and then on top of that, they would have to have the positive brain scan. So that what you're looking at is an even smaller number than what you're saying. It's not all girls that are getting this.
But who has the right to mandate this girl to do it? The girl itself or their parents?
It's similar with other ways of evaluating. Is it the same? If teachers evaluate the behavior of students and then have to report it, the students don't get a say. The parents don't quite get a say, but it's still reportable. It's in the interest of the child, but it is outside of the realm of the family or the child himself.
Okay.
Great, my turn. Thanks all for being here. I can see your beautiful faces. So I'd like to support Ian's thesis that these scanning technologies are still in their formative phases and that their use as diagnostic tools should be approached rather skeptically. However, what I really want to talk about is the actual language of the prompt. It says that brain scans should be mandated for teenage girls with behavioral disorders. My understanding is that any sort of mandate as this would be patently illegal in that it violates our reasonable expectation of privacy as well as our expectation of personal sovereignty. We, as citizens of this great country, have the right to control our own bodies and control what happens to these bodies and our privacy there. And that's in the Constitution, the Bill of Rights, also common law. So even if these brain scans were 100% accurate, which they are not, forcibly scanning these young women is certainly illegal, and unless we use the Patriot Act, not the American way. So that aside, if we can get by the law, on the more philosophical side, that's been raised a few times before, I really want to talk about the implications of establishing a society where it's appropriate to label people based on their physicality, that is what they are, the shape of your brain, versus what you do. So I'm not sure, so we can look for examples of this elsewhere, but if we do have these brain scans, if we mandate brain scans for teenage girls, I think we were considering this more all teenage girls with behavioral disorders, so we may be talking across purposes here. But if you did mandate teenage girls to have brain scans if they had behavioral disorders, then you logically have to utilize this information somehow. And as Brian brought up, 16% of young girls have behavioral disorders. So we could take that information and separate these girls, maybe give them special schools. That might be an extreme option. But as another example, we already have people who are more or less separated, those who are labeled as having learning disabilities. And the literature says, to quote nobody, that these people, once you label them as having a learning disability, they begin to think of themselves differently. Once you have a learning disability, you think of yourself as dumber. You try less hard, and it's scientifically proven that people with learning disabilities work less hard. Learning skills. Also, once you label someone as having a learning disability, you put them in special classes, for example, special education classes, and research shows that teachers who teach kids with learning disabilities are less motivated. They view their students as being dumber, and these students thereby receive inferior education. So the problem with this type of thing is that the result of this label is a validation of the label itself. So here in this example, we create underachieving learning disabled children by labeling them underachieving and learning disabled. And something similar would happen if we were to start taking these girls with behavioral disorders, scanning them and pinning a label, this girl's got a tiny amygdala. We would validate and normalize asexual behaviors and perpetuate this, animosity between us and that group of girls, and they would be treated differently. So, in conclusion, mandatory brain scans are not only illegal, but immoral, and stereotyping children is not really a treatment for behavioral disorders. It's just a burden on those children and society.
So a lot of what you said was about sort of the stigma associated with being labeled as having a disorder. But if anything, I feel like this would eliminate the stigma. Without this clear diagnosis, these kids are labeled as just being bad kids. Like, they just have behavioral disorders, they're just bad kids. And they're labeled as such, they're grouped as such without any interference from the medical field. But by having this scan and knowing exactly what is wrong and pinpointing it, it eliminates the stigma that this kid's bad kid. They have a disease or a disorder.
Do you think kids can differentiate between a reduced volume of amygdala and being called dumb or being called a bad kid?
Say that again?
Do you think a child understands what being labeled as having a reduced amygdala size would mean, as opposed to just having a clinical diagnosis for their disorder?
I don't think there would be a difference.
So effectively, that doesn't make sense.
So effectively, it's like them having what? I mean, it's like them. Okay, if you have a broken arm, you go to the doctor and get your broken arm fixed. If you have a small amygdala, you go through therapy, you go through treatment to make sure that you.
Right, but we already have treatments for behavioral disorders. This is just another label.
This is another dimension to the diagnosis, so that you can know exactly what is wrong, so that you can have more information when you actually do go to treat this disorder.
Do we have targeted treatments for this type of thing?
Yes. Yes, actually the diagnosis and treatment in primary care, let's see. Chronic disorder, when left untreated, has a very negative prognosis, but with early treatment, if you catch it early enough.
But knowing that someone has a reduced amygdala size doesn't help treat, doesn't help diagnose that.
It helps diagnose if they have chronic disorder versus ADHD or some other.
But by what you were saying, if you have cognitive disorder, then you get a scan. So you already know.
If you have a behavioral disorder, you get a scan to determine if you have cognitive disorder.
Okay.
I guess so.
Okay, so, the negative 4 minutes.
Okay. Just want to spend a little bit of time talking about the fact that this is mandated and some of the criteria that might go into determining who would get a mandated scan. If we're looking for behavioral changes or behavioral misconduct, which would then force somebody to get a mandated brain scan, who's determining this? Are we leaving this up to parents? Are we leaving this up to teachers, guidance counselors? I mean, I took a look really quick before, and just took a look at some people were saying, parents, about their own teenage daughters, about some of the reasons they thought their child had behavioral problems or issues. And there were things like the teen disagrees with them and they need to go to counseling. Or they think that their teen uses their devices, cell phones, too much. And that, or the kid, maybe the kid hangs out with other kids they don't like, or acts entitled, or argues with the parent. I mean, these are just things of being a teenager. I know that some people in this room have teenage girls and have managed to survive it and get through it okay. So are we going to leave this decision to the parents, which would be the ones that probably would be able to know best for somebody at that age? But are we going to take, if we take that power away from the parents and then give it to the teachers, to the schools, then that's not appropriate. Then we're forcing this testing on parents, teachers. What about those that have perhaps religious stigma with this? And there is some stigma as well with actually having the test. I know Michael gave the example of lice. I mean, it was pretty embarrassing, I imagine, if you were one of those kids that got caught with lice in the gym, and they sent a letter home to every parent saying that they caught lice in one of the child's hair, and therefore, you know, everybody needs to test all their children for lice for a little while. I mean, that can be pretty embarrassing. And there is just the privacy issue as well. I mean, so if we take these brain scans and then we do separate it out, and we say that people have smaller amygdalas, then do they go into the classroom and you go, oh, this is Johnny, he's got a smaller amygdala. You know, be a little nicer to him. That's that private information that we're then sharing with teachers, that we're then sharing with classmates, that may not be appropriate. So mandating the therapy might not be appropriate. And even if we just do these scans, there is some concern over whether or not we'll actually have success with some of the behavioral therapies that we have. There's conflicting studies whether or not that things like behavioral therapy or cognitive therapy is actually cost efficient, whether it's successful. It costs about $150 an hour to go to a therapist on average. And a lot of insurances out there don't cover mental treatment by default unless you have an additional rider on the insurance. So not all these treatments would be covered by insurance. And if somebody has a brain scan and finds that there is a behavioral issue with it, are they then mandated to go get treatment? I don't know.
Okay. All right, so just to address the position that we're labeling these kids and we're separating them out, well, that's not essentially what we're doing. What we're doing is saying, okay, in your file, you've had this finding. That doesn't have to be shared among teachers. That doesn't have to be shared with the school system in general. This could be between the patient and their doctor. You know, because this has nothing to do with the sense that you have to share this information. You don't have to tease it out. You don't have to tell the whole world and say, okay, you know, all the kids with small amygdalas over there. You know, you're really just saying, look, this is of importance. We're noting it down, and that's pretty much it. Also, the effective treatment situation, well, that's mostly because we don't know what's wrong with them. You know, it could be they have family issues. It could be there's a genetic component to it. It could be that there's just a general psychosocial problem, whether, you know, they're in a low economy, they get abused by their parents, etc. And this kind of helps narrow this down. Coming back to a major point from that we have, that we're trying to avoid misclassification. With such a highly heterogeneous condition, you're as often as you're getting the treatment right, you're probably more often getting it wrong, and you're probably really spending a lot more money figuring out what works than actually doing what works. And if we can tease out, at least primarily, if we tease out that these people with smaller amygdala respond to X treatment, well, then we can take them out of the guesswork and say, all right, all these people with small amygdala who have behavioral disorders can get this treatment, as opposed to saying, okay, well, let's run the battery of let's run the battery of treatments. Let's see what they respond to. I think that also helps justify the costs of these scans. One more thing. If we have an increased load of scans, there's going to be pressure over time to decrease the cost of these technologies. So conceivably, initially, yes, it'd be very expensive. I'll concede that. But I think if this became the norm, that we can justify the cost because the price of the scanning will go down or better technologies will emerge.
Okay. Yeah, that was looking at it wrong. Excellent. I think that you've done a very good job of reducing the situation to a very specific set of people. But what you're really describing is a scientific study or clinical research. And as the prompt is stated, this is mandating scans for all girls. That aside, that you know that you concede that once you have this diagnosis of whatever, small or amygdala, you don't know, or once you have this diagnosis of conduct disorder, you don't know what's wrong. So we really have no way of correlating these scan results with, we don't have a good causality here. And so really what we need is more research. I think that one of our major points was that these scans are not accurate enough yet, and the research has not been done. Would you agree? What do you say about that? Do you think in the future, do you say that now? Could you say that now that they're not appropriate, but in the future that it might be?
Yeah.
Oh, it's not?
No, you just
Sorry, I'm just talking. Don't worry about it.
Just talk at us.
Okay, yeah. You don't know that. You would have said no. We can't establish causality now because the research hasn't been fleshed out enough. If we could establish a direct causation between genetics, environment, a smaller amygdala, and these disorders, then by all means, we could do that. But we're not there yet. We're not at a point where we can mandate these scans. Another point is that you said that this labeling, back to labeling, you said that this labeling wouldn't be necessarily there, but really labeling is unavoidable. I had a speech disorder when I was a kid, and I would go to the office every Thursday and get that, and kids knew about that. It's not, you don't have to tell people for them to know about that stuff, and you don't have to tell people for them to treat you differently because they know something about you. So that's not really, I think that's a really nice point, but it's also not really valid in this sort of setting that we're talking about. We're talking about high school girls, and they talk. If I know anything about that.